Thank you for joining us for an OncLive peer exchange panel discussion on precision medicine and non-small cell lung cancer. Results of recent clinical trials in lung cancer have led to transformation in thoracic oncology as we persist in exploring new therapeutic targets. In this OncLive peer exchange discussion, precision medicine and non-small cell lung cancer, ramifications of recent data, I'm joined by a panel of experts in lung cancer clinical research. Today we will discuss key data that impacts the way you treat your patients, including updates from the 2019 ASCO annual meeting. I'm Dr. Benjamin Levy, Associate Professor of Oncology and Clinical Director of Medical Oncology at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. Participating today on our panel are Dr. Josh Baumel, Assistant Professor of Medicine at the Perelman School of Medicine at the University of Pennsylvania, Philadelphia, Pennsylvania, Dr. Ross Kamage, Joyce Zeff Chair in Lung Cancer Research at the University of Colorado in Aurora, Colorado, Dr. Bob Doble, an Associate Professor in Medicine at the University of Colorado School of Medicine in Aurora, Colorado, and Dr. Zofia Piotrowska, a medical oncologist at Mass General Hospital and instructor at Harvard Medical School, Boston, Massachusetts. Thank you for joining us. Let's begin. So I think we've come a long way in the past 5 years with the identification of actionable mutations and the delivery of targeted therapies. Lung cancer truly has been, I believe, I think we all believe, poster child for precision medicine. The story obviously begins with EGFR and ALK, but again, we've made some headway in other mutations that may be relevant and need to be tested. So I'll ask you first, what are the recommendations currently for testing, molecular testing for advanced stage adenocarcinoma of the lung?
Yeah, I think testing is incredibly important, and not just testing, but also I think importantly waiting for the results of the testing to be sure you have all the information in hand when making a treatment decision. According to the NCCN guidelines, all patients with stage 4 non-squamous lung cancers should be tested, and those with squamous cell cancers, it should be strongly considered. And I think now it's really important not just to look for the common targets with approved therapies like EGFR and ALK and ROS1, but we are seeing more and more of these rare novel targets that are becoming actionable, that have great therapies for them. And I think, in my practice, doing a broad panel up front, doing next generation sequencing-based testing right at the beginning so that you know all of the information about the patient's cancer and can select the appropriate first-line therapy for that patient. I think that's critical and certainly is something that I do routinely for my stage 4 patients.
So how does this go down in your institution? You do comprehensive genomic profiling, in addition do PD-L1. How do you integrate PD-L1 into this process?
Yeah, so we do both. The PD-L1 does get reflexively done by our pathologists on lung cancer, on any pathology that comes back as non-small cell lung cancer. So we get that back. Usually, actually, we get that back quicker than we do the molecular testing, which is an important point because often there's an impetus to treat based on PD-L1, but in fact, it's important to wait for the molecular to come back. We have an in-house NGS panel that usually takes about 1 to 2 weeks to come back, as well as an RNA-based fusion panel that picks up some of the
two different sequencing panels.
Yeah, exactly.
Okay.
To cover, I think all of the common and less common targets.
Okay, so you get all one-stop shopping. It all comes back. And how long? What's the turnaround time for the NGS at your institution?
I think realistically we can say 2 weeks. Okay. Sometimes we get lucky; it's a little bit shorter, but I think on average about 2 weeks from the time of the biopsy.
So within that comprehensive testing, you're getting EGFR, you're getting ALK, you're getting ROS, you're getting BRAF, the approved agents, but you're also getting these rare genetic alterations that are potentially actionable, MET, RET, HER2.
Yeah, I think one of the nice things has been that the panel has been expanded. Each year as new kind of targets are found, for example, NTRK and other things, the panel has been able to be adapted to include really anything that's potentially actionable. Josh,
talk a little bit about in-house panels and the value of bringing NGS. You're at Penn and you're doing an in-house assay there. What's the value of having an in-house assay versus farming it out to a company like Foundation? And how do you have to coordinate with everyone else that's a part of the tissue procurement and the processing to get things done within the institutional walls?
So I think that there's a lot of advantages to doing it in-house because the pathologist get the tissue and then they can immediately get it started to going towards the pathway, as opposed to if you have to send it out, then it's a whole separate process. I will say that whatever testing is done, one of the important things is knowing what your testing is. and knowing what the limitations of that test are and what it's actually looking for, what it's not. One of the major barriers that I've seen from colleagues in the community is they say, they do a test, they say, this tumor was tested. And they say, oh, it's tested. And I said, well, what test happened? And they said, well, it was tested. And it's important to know more than that, unfortunately, because if you do a DNA-based NGS assay, it may not be able to detect fusions. And so when you go through the list of things, it might say, we're looking at NTRK. But that's actually only looking at NTRK mutations, which are not actually clinically actionable. And so it's very important that you know not only that the tumor is tested, but how it's tested. And I think that having it as an in-house assay, which we have, and we have a similar process to what you were describing, Zosha, where we have a DNA-based assay and an RNA-based fusion assay, really allows us to get this moving as fast as possible so we can get the results and act on them.
I think I would add too, I think that's a good point. Sometimes you see patients where testing has been performed, but sometimes too, the testing was done a year or two prior. And maybe that, it's not just important to see what test was done, but really what genes it covered.
Absolutely.
Because, there are some cases where you may not, it may not actually have been tested for MET, and now it's important to go back and retest.
And one other factor which is important is what piece of tumor was being tested. So I think that often I've seen patients have bone biopsies undergo testing, and the decalcification process degrades the DNA. And so if I have a patient who comes in and they had a bone biopsy and that's what their NGS is based off of, I will often repeat the test with a new biopsy because I just don't think we can rely on those results.